Good morning, everyone. I am Dr. Sivasubraminiyan, the Assistant Professor in Radiology, SLIMS, Puducherry. Today's topic will be congenital abnormalities of the posterior fossa. Posterior fossa predominantly contains the cerebellum and the medulla oblongata and the pons, and you have the fourth ventricle in the middle. So you have a bipartite origin of the cerebellum from two neurotransmitter phenotypes. There is one that is a cerebellar ventricular zone that develops from the GABAergic PTF1A pathway, and the rhombic lip that is developing from the glutaminergic MAT1 pathway that is denoted as blue. You can see here the inner layer is the rhombic lip. So the cerebellar ventricular zone has a PTF1A gene that segregates cerebellum from the brainstem. From the ventricular zone, adjacent to the roof of the fourth ventricle, newly differentiated neurons migrate radically within the cerebellar enlarge and form the Purkinje cells, stellate cells, the basket cells, and the deep cerebellar neurons that are typical of the adult cerebellum. And then you have the MAT1 gene, which is the bone metabolic protein derived signal from the roof plate, and that causes the granule cells to migrate tangentially over the enlarge to form the external granular layer and over the Purkinje layer. With mitotic signal from the Purkinje cells, that is SSH genes, the granule cells proliferate and then they inwardly migrate. So, disorders of cerebellar migration, that is the RELN gene mutation, typically leads to leukoencephaly, corpus callosal agenesis, and dysplasia of the cerebellum. And other congenital muscular dystrophies also cause retinal abnormalities and cerebellar dysplasia. Coming on to the anatomy of the cerebellum, you have the lobes, lobules, and fissures. You can see the vermis is in the midline of the cerebellum, and you have the lobes on either side of the cerebellar vermis. And you have various parts of the vermis like lingula, centralis, culmen. And then posteriorly, you have the declive, and you have the folium, the tuber, the uvula, the pyramid, and the nodulus. So these are the central divisions of the cerebellum, and you have the various lobes and fissures in the cerebellum. And you have this fissure, which is the primary fissure that separates the superior and inferior aspects of the cerebellum. And you also have the pyramidal fissure that separates the secondary lobule of the cerebellum from the pyramidal lobe. And you have the precentral fissures that delineates the lingula and the centralis, the preculminate fissure that delineates the centralis and culmen, the posterior-superior fissure that separates the declive and the folium, and the horizontal fissure that separates folium from the tuber, the pre-pyramidal that is separating the tuber from the pyramids, and the secondary fissure that separates pyramids from the uvula. Coming on to the afferents and the efferents. The afferent fibers are mostly fibers from the basis pontis and spinal cord synapse, and the climbing fibers of the contralateral inferior olive synapse with the Purkinje dendrites, and the fibers from the locus ceruleus and the raphe nuclei and the substantia nigra from above synapse with the Purkinje cells. The efferents, when you take, they are to the brainstem nuclei and other cerebellar nuclei, they come from the Purkinje layer. So this is a normal anatomy of the cerebellum, and you see the two fissures here. The one that's sitting superiorly is the primary fissure, and the other one inferiorly is a pyramidal fissure. And here you can see the fourth ventricle cleft and the anterior roof of the fourth ventricle. The normal anatomy of the posterior fossa that is seen on the axial T2 weighted image. You can see the orientation of the cerebellar white matter and the cerebellar folium. They have an onion-like orientation. So what is the role of MRI in evaluating the pediatric posterior fossa? You have the 3D T1 weighted MR sequence in axial, coronal, and sagittal reconstructed planes that shows excellent differentiation between gray matter and white matter with high resolution anatomical information. And then you have the T2 weighted axial and coronal images that have high resolution anatomic information. They delineate the cortex and the white matter and the gray matter nuclei. You also have a recent advance in radiological imaging called the diffusion tensor imaging, and you image the white matter microstructural integrity, and the white matter tracts can actually be imaged, including the morphology and the direction of the white matter tract. The direction of the axonal spread can also be studied in the diffusion tensor imaging. CIS, which is a 3D sequence, which is called as constructive interference in steady state, is a very often used sequence for cranial nerve imaging, and it has also been used extensively in the imaging of the cerebellar folia, the ventricle, and the foramen. And then you have the susceptibility weighted axial image that picks up blood and blood products. When it comes to cerebellum, naming is everything. Precision in the use of language, whether verbal or written, is a reflection of the precision in the scientific thought and patient care. So, for accurate diagnosis of a complex posterior fossa abnormality, you need to name the abnormality correctly so that you can manage it in the right direction. So, you need to understand two basic concepts. That is, what is a malformation versus what is a disruption. A malformation is a congenital morphological abnormality of a single organ or a body part due to a cellular or a molecular pathway involved in organogenesis. That is, the primary embryology itself is abnormal. So the molecules in these pathways can be altered by gene mutations or teratogens or combined effects. On the other hand, a disruption is a stoppage of a normal growth due to a vascular cause or an infection or a hemorrhage, and it has a normal developmental potential, but because of vascular factors, it is disrupted. So we need to understand these two terminologies and these two concepts well to actually see how to differentiate them on imaging. So we have few terms like cerebellar hypoplasia, which is defined as a reduction in the cerebellar volume with a maintained shape and normal fissures, and it is stable over time, and it can be either a malformation or a disruption. The other thing is a cerebellar agenesis, where there is near complete absence of cerebellar tissue or a remnant anterior vermis or flocculus, and it is only a finding and does not suggest whether it could be a malformation or a disruption. So a complete vascular cause can also lead to cerebellar agenesis, whereas a genetic abnormality can also lead to cerebellar agenesis. The other one is called as pontocerebellar hypoplasia. This is important. It was conceptualized by Peter Barth, and it denotes a degenerative prenatal disorder, which is congenital, and it is a malformation, and it is not a disruption. Moving on. We also have terms like cerebellar dysplasia, where there is an abnormal folial pattern and arborization, and you usually have syndromes associated with it, like Joubert syndrome, etc., and it is a malformation. Next is a cerebellar dysmorphia, that is a focal bulky folia crossing the midline, like that we see over here, and it is a malformation, usually associated with NF1. Cerebellar atrophy, that is a term that we use for irreversible loss of cerebellar tissue, and there is a caveat here: it can be a malformation or a disruption, and you have to differentiate between a pure cerebellar atrophy versus a cerebellar plus syndrome, and it is usually progressive. So there is, in an attempt to classify cerebellar disorders, there is a landmark study by Patel and Barkovich titled Analysis and Classification of Cerebellar Malformations, in an attempt to systematically categorize all the cerebellar disorders and what is to obtain a rationale of what is exactly happening and how they evolve, and whether it is a malformation or is it a disruption. And so the role, so we need to so I've shared the journal title and the article here, and this is a very good read, and this clarifies a lot of concepts in understanding about cerebellar dysmorphogenesis. So we have an imaging-based classification that says, is it hypoplasia or is it a dysplasia? And is it focal or is it diffuse? And are the other parts of the brain other than the cerebellum involved, like the brainstem or supratentorial brain parenchyma? So in that particular study, they found that there was diffuse cerebellar dysplasia associated with other congenital abnormalities like muscular dystrophy in Lissencephaly, and some were antenatal cytomegalovirus infection, and all had associated cerebral abnormalities. We also have focal cerebellar dysplasia, like in Rhombencephalosynapsis or Joubert syndrome, and this is a variable cerebral dysplasia was seen in these cases. And in the other non-syndromic cases where there was heterotopia or hypoplasia or a focal cortical dysplasia, the cerebrum was normal. So another classification was given by Demerel et al. And this was based on the abnormalities in the foliation and fissuration in the cerebellar hemispheres. So each and every lobule is a folia, and in the folia you have the CSF clefts that go within the seem to go within the cerebellar parenchyma, and you can see that it is seen in the periphery of the cerebellar parenchyma. So that is the foliation, and the fissuration is actually somewhat more major, and it divides the cerebellum into various lobules or various lobes. So we have the type 1A and type 1B. This is type 1A, that is abnormal fissuration limited to the vermis, and it is an incidental finding. It did not have any clinical relevance. Whereas the other one was type 1B, involving the anterior as well as the posterior vermis with hemispheric extension. And you can see that there is associated cerebral abnormalities and clinical and cerebellar signs that may occasionally be seen. And next was the type 2 abnormality, where there was abnormality in fissuration as well as foliation, as well as bumpy gray-white interface of the cortical gray matter, and cerebellar hypertrophy with cortical thickening. So these were classified as type 2 abnormalities. So our idea of conceptualizing cerebellar anatomy and cerebellar morphometry is to gain a perspective of the possible genotype of the individual who has been affected from the phenotype to the genotype. So we have neuroimaging that helps us, and then from neuroimaging you go to a genetic disorder. You suspect that this could possibly be a genetic disorder, and then you do the genetic testing, and you do the diagnosis and prognosis and treatment, and then for follow-up you again come for neuroimaging. So this is the imaging phenotype to genotype dogma that we follow in the radiological branch. So let's discuss Joubert syndrome. Joubert syndrome is a sort of a syndromic association of cerebellar and brainstem abnormalities that can be associated with other anomalies as well, because the primary pathology in Joubert syndrome is a disorder of migration. So you have an intimate connection with the cilia. So in the primary cilia, they have a basal body and a microtubule, and there are various genes localized to the basal body and the cilia, and these are the embryological structures that aid in the migration of all the neural structures. So you have various genes that are located in the basal body and the cilia, like the AH1, NPHP1, and CEP290, TMAM67, and GTPase regulatory interactive protein called the RP-GRIP-I1L. So it is characterized by defective axonal migration, and that leads to the classic clinical picture of molar tooth sign, which we will be seeing subsequently. It is an autosomal inheritance, and it is rarely X-linked, and the defective protein coding for non-motile cilia is responsible for the same protein that is coding the non-motile cilia also codes the retinal photoreceptors and renal epithelial tubules and the biliary and the neuronal proliferation and axonal migration components. So you have posterior fossa abnormalities, corpus callosal dysgenesis, malrotation of the hippocampus, cephalocele, ventriculomegaly, and migration anomalies. And As far as the renal epithelial tubules are concerned, you get nephronophthosis, and in the retina and in the eye, you get coloboma and retinal dystrophy, and in the liver, you get congenital hepatic fibrosis, and in the periphery, you get polydactyly. So Joubert has the classic molar tooth sign, which is an elongated, thickened, and horizontally oriented superior cerebellar peduncles with deep interpeduncular fossa and a hypoplastic bonus. It is associated with dysmorphic tectum and midbrain and a small pons. Neuroimaging is of limited value in classifying the genetic subtypes of Joubert syndrome. It can only give a broad orientation to the possible diagnosis of a Joubert syndrome. So this is an abnormal brain MRI. Here we see that you can see that the superior cerebellar peduncles are abnormally elongated, and this is the diffusion tensor imaging, also showing the abnormal white matter tracts that go along the superior cerebellar peduncles. And you can see the ventricle, fourth ventricle is abnormally large, and the vermis is showing hypoplasia. So this is a normal anatomy. This is an axial color-coded fractional anisotropic map at the pontomesencephalic junction, which shows the superior cerebellar peduncles, which is the green-blue, seen in arrows, and the transverse fibers at the decussation or the ventral tegment of the superior cerebellar peduncles, that is the arrowhead. Coming on to Dandy-Walker malformation. It is also called as DWM. It is sporadic with a low risk of recurrence, and rarely it can have chromosomal anomalies that are associated. And it clinically presents with raised intracranial tension less than 1 year of age with macrocephalus. The key findings are a cerebellar vermian hypoplasia, which is inferior with upward rotation of the superior vermis, and a cystic dilatation of the fourth ventricle that displaces the normal cerebellar hemispheres anterolaterally. And you also have an elevated tentorium, trocula, and the transverse sinus. This is called as troculo-lambda inversion. And then you also have other associated abnormalities that predict a poor outcome, like a corpus callosal agenesis, occipital encephalocele, polymicrogyria, or a heterotopia. So this is a sagittal image showing a Dandy-Walker malformation. There is a large cyst in the posterior fossa, Vermian hypoplasia with obstructive hydrocephalus. Increase in the intracranial pressure with dilatation of the lateral ventricle. So, as far as cerebellar involvement in migration disorders is concerned, you generally have a hypoplasia of the pons and cerebellum with RELN and VLDLR mutations. The vermis is more involved than hemispheres, and tubulin alpha and beta receptor mutations, they cause associated, in addition to cerebellum, they also cause pontocerebellar hypoplasia, Pontine clefts, and asymmetric peduncles. And it's usually associated with polymicrogyria and mesencephaly. So this is one tube A1A mutation showing cerebellar dysmorphogenesis, and so we call it as a dysplasia. And there is a kinking of the pons and the brainstem. So there is a pontocerebellar dysplasia and supratentorial abnormalities like the dysmorphic caudate nucleus. Now coming on to Rhombencephalosynapsis, this is a condition which occurs where there is a vermis is absent, so there is no midline that is separating the two cerebellar hemispheres, and so you get a tigroid pattern of white matter tracts that are abnormally oriented and connect the right and left cerebellar hemispheres. So you have continuous cerebellar hemispheres, and it's mostly non-syndromic with a low recurrence, although it can be associated with vacuolar anomalies and some syndromes. So there is continuity or fusion of the cerebellar hemispheres with a horseshoe arch and a keyhole fourth ventricle and the horizontal folial pattern of coronal images, and it can be associated with hydrocephalus or absent olfactory bulb. So this is a case of Rhombencephalosynapsis. You can see that the vermis is absent and you have a horizontal cleft over here. So this, and there is continuity of the cerebellar hemispheres and the dentate nuclei. They appear fused. Macrocerebellum, like the name suggests, it is increase in the size of the cerebellum and with preserved shape, and it is associated with ventriculomegaly and white matter abnormalities. So this is an enlarged cerebellum called as macrocerebellum, and you can see that the midbrain is also showing corresponding areas of abnormality. Now coming on to cerebellar dysplasia. So now we have understood that dysplasia is an abnormality of foliation and fissuration. So it is defective white matter arborization that presents on the imaging as abnormal fissuration and foliation. So the gray-white junction is also obscure. So it is associated with other anomalies, and it is quite characteristic of a defective migration rather than just a vascular insult. You can see the normal morphotexture of the cerebellum itself is altered. You remember the onion peel appearance that we saw on the T2 axial image initially, and you can see how abnormal this cerebellar foliation is, and you have an abnormal fissuration also. So cerebellar and brainstem malformations are together called as pontocerebellar hypoplasia, as conceptualized by Barth. And you have a hypoplasia superimposed on atrophy, and you have a dragonfly appearance where you have the small cerebellar vermis and the wings of the dragonfly, which is actually the small cerebellar hemispheres. And the relatively preserved vermis is the body of the dragon, and it occurs in extreme prematurity and cask mutation, like in disorders of glycosylation. So there are various subtypes of pontocerebellar hypoplasia, where type 1 is the involvement of the anterior horn cells, and you have the genotype there. And type 4 is the most important one with severe neonatal course, and it has TSN54 mutation. And the type 5 is lethal, again with TSN54 mutation. Depending on the degree of penetrance, it either becomes type 4 or type 5. And associated gonadal abnormalities in type 7, and type 9 with dysgenesis of corpus callosum, and the type 10 with axonal neuropathy. So this is type 2 pontocerebellar hypoplasia, showing the classic dragon fly appearance with a relatively preserved cerebellar vermis and the superior cerebellar vermis and the marked hypoplasia of the bilateral cerebellar hemispheres. Then you have the Pontine tegmental cap dysplasia, which is again another variant of a Pontine and midbrain abnormality that is associated with a cerebellar abnormality. So you have the flattened ventral pons with hypoplastic middle cerebellar peduncles and absence of transverse Pontine fibers on the diffusion tract tensor imaging, which are characteristic of Pontine tegmental cap dysplasia. These are rare and they don't primarily involve the cerebellum. They are predominantly brainstem malformations. So fractional anisotropy map, the middle cerebellar peduncle is shown in green over here on either side, and the corticospinal tracts that descend are shown in blue over here, and the medial lemnisci are also shown in blue with an arrowhead. And you have the transverse pontine fibers that are oriented on the red. So this is a normal anatomy, and these transverse pontine fibers are predominantly affected in an abnormal anatomy. Moving on, we have cerebellar disruptions where there is agenesis of the cerebellar hemisphere. These are due to infections or antenatal toxin exposure or hemorrhages. There is no mutation or intrinsic abnormality. It is a disorder of, it's a disruption of the normal development of the cerebellum. So you have a near complete absence of cerebellar tissue. You can see just a small remnant of a cerebellar hemisphere with a large cyst filling the entire posterior fossa. And you can see supratentorial abnormalities as well. So there is global cerebellar hypoplasia, which can either be malformation or disruption. In malformation, you have the trisomies, and the Zellweger syndrome. Whereas in disruption, you have the CME infection and maternal alcohol intake, drug abuse like cocaine. So in MRI, you see a normal or near-normal shape with reduced volume with prominent subarachnoid spaces and associated supratentorial calcifications with CME infection. So this is global cerebellar hypoplasia. You can see the susceptibility weighted image showing cerebral supratentorial calcification, and this is a loss of cerebellar volume suggestive of a congenital CMV infection. Sometimes you can have a unilateral cerebellar hypoplasia that is caused by hemorrhage, and there is volume loss in the hemisphere with or without involvement of the vermis. And usually the hemorrhage is demonstrated in the susceptibility image, and if it happens in the 24 to 32 weeks of antenatal life, you need not necessarily see hemorrhage, and absence of hemosiderin does not exclude cerebellar hemorrhage because the blood-brain barrier is still porous and it can permeate the hemosiderin macrophages to exit the cerebellar parenchyma. And you also have porencephalixes that are part of the sequelae. You can see there is unilateral cerebellar hypoplasia, and you can see the normal appearing left cerebellar hemisphere over here, and near total absence of the right cerebellar with the arrow pointing to the remnant superior aspect of the right cerebellar hemisphere, which is seen. Okay, and we come to cerebellar cleft, which is a residual disruptive change secondary to fetal cerebellar hemorrhage associated with schizencephaly. You get cleft from the cerebellar surface through the parenchyma to the fourth ventricle with maloriented folia and irregular gray-white junction with abnormal arborization and volume reduction. So you have a cleft over here with reduced volume of the left cerebellar hemisphere. So this is a disorder of disruption and with abnormal foliation. And you have vanishing cerebellum in myelomeningocele because the cerebral and cerebellar pressures of the CSF are altered. The hemodynamics is altered in the myelomeningocele, and you have an abnormality of the posterior fossa with reduced cerebellar volume, which is a very typical finding of Chiari 2 or myelomeningocele. So cerebellar injury secondary to prematurity occurs from 28 weeks to term, and there is a 30-fold increase in the surface area of the cerebellum normally during this time. And it requires high energy, especially from 24 to 32 weeks, where injuries like primary injuries in an extreme preterm infant can be very devastating. And there is arrested cerebellar development with reduced volume, hemosiderin deposition, and hydrocephalus. So susceptibility weighted imaging identifies areas of hemosiderin deposition. So this is the ultrasound image of the mastoid fontanelle of a 14-day-old neonate, which is an extremely preterm neonate born at 26 weeks of gestation with areas of cerebellar hemorrhage represented as bright areas. And this is a small posterior fossa with the abnormal Pontine belly, and you can see the skeletonized appearance suggesting cerebellar atrophy, and hemosiderin deposition indicated as a T2 hypointense nodular focus. So this is classic of prematurity and causing cerebellar vascular injury. So the relative immaturity of the neonatal Purkinje cells is thought to have a protective effect on the cerebellar gray matter in hypoxic ischemic injury. And cerebellar injury may be secondary to synaptic degeneration via the thalamocerebellar pathway. So if there is a HIE that involves the thalamus, and therefore you can have a antegrade degeneration of the white matter tracts that come via the thalamocerebellar pathway. And Vermeer involvement may be severe as an independent predictor of severe hypoxic ischemic injury associated with a significant neurological disability. So we have covered the more common causes, and the less common causes of abnormal posterior fossa are the Krabbe's disease, which is a galactocerebrosidase enzyme deficiency with the failure of myelination, and neuroimaging shows abnormal signal intensity in the thalamus, corona radiata, cerebellar white matter, and the dentate nuclei. You can see enlarged optic chiasma in Krabbe's disease. It's a disorder of metabolite deposition and nerve enlargement in the prechiasmatic optic nerve and bilateral dentate hyperintensities. Next is the Pelizaeus Merzbacher's disease, which is a disorder of dysmyelinating disorder or a hypomyelinating disorder caused by genetic mutations. And you also have associated cerebellar white matter abnormalities in this. You can see the non-myelinating cerebellar white matter tracts as well as the corticospinal tracts. So an logical approach to a cerebellar abnormality would be, is there a morphological abnormality of the cerebellum? Then the question of studying it further arises. Is the volume reduced or is it normal? So if the volume is reduced, then it is cerebellar hypoplasia. If the volume is normal, is it near complete absence of the cerebellum? If so, it is cerebellar agenesis. If not, is there reduced volume of the pons and cerebellum? If yes, then it is pontocerebellar hypoplasia. Or else, you should ask the question, is there an abnormal foliation or is there abnormal white matter arborization? If so, it is a dysplasia and it is a malformation. If not, you should ask, is there enlargement of the cerebellar hemisphere with widening of the interfolial spaces? Then, if yes, then it is probably a cerebellar dysmorphia. If not, then you need to follow up the case and there should be progressive enlargement of the cerebellar infratentorial spaces, then it's probably a cerebellar atrophy. And if it is non-progressive, then it is probably a cerebellar hypoplasia. So to summarize, we have cerebellar hypoplasia, atrophy, dysplasia, dysmorphia, pontocerebellar hypoplasia, agenesis, and abnormal areas of associated supratentorial abnormalities. So, how is the hemispheric development? How is the Vermean development? Is it normal? And how is the pattern of folia and fissures? Are they normal or abnormal? And then what are the characteristics of the hemispheres and the worms? Is it dysplasia? If it is a dysplasia, is it focal or diffuse? And if it is a hypoplasia, is it focal or diffuse? Or is it complete absence like aplasia? So the size of the posterior fossa and the mass effect are all other secondary signs that you should also see when you look at a syllabus. So this is to summarize the entire thing in a nutshell. The first few are cerebellar hypoplasia with reduction in the cerebellar volume, absent development called the cerebellar agenesis, and abnormalities of the midbrain as well, that with hypoplasia of the cerebellum called as pontocerebellar hypoplasia, an abnormal morphology of the fissure, that is dysmorphia, and skeletonization of the cerebellum, which is cerebellar atrophy. I hope this made sense. I hope you enjoyed the lecture. Thank you.